Next speaker is Dr. Tatjana Koenig. She's a pediatric surgeon with vast experience in treating complex pediatric conditions. Currently, after being consultant in University of Mainz, she is changed and she moved to Hannover Medical School, where she is a consultant of pediatric surgery since February this year. She also studied sports. Also, her special interest in the topic she will talk about physical activity in children with and without esophageal atresia.
Yeah. Thank you, Professor Lacher. Ladies and gentlemen, I'm very happy to show this data here because most of the studies actually happened in cooperation with KEKS, and I'm very thankful. And I'm happy to tell the KEKS members what was the outcome of the studies they participated in. So, how much should children move? And I think especially if you look at the ages between 1 and 2 years, that is a lot more physical activity that the World Health Organization recommends than we would actually think. Of course, this is not going to some sports club or doing defined sports, but it's just movement. Have the ability to move in the surroundings that they are at. And then at the ages of 3 to 4, you actually start with what we would call sports. And then later on, when you're a teenager, you should work out at least 60 minutes each day. And that's what they call moderate to vigorous intensity. That means that you're active in a way that makes you sweat and makes you breathe a little harder. And this also applies to all children with chronic conditions. Now, if you have esophageal atresia, you might miss out on a lot of opportunity, especially in the early years of your life, because you are in the hospital all the time, or you have infections, or you have respiratory problems even at rest. But what they say is doing some activity is better than doing none at all. And any activity you do will benefit your health at whatever age you're at whatever health conditions you have. And what we learned during the past years is these activities should be enjoyable so people stick with it. They offer variety and they are appropriate for the age and ability. So I did my doctoral thesis on obesity care in children. And what there was said is all obese teenagers should go to the swimming pool or they should swim because it's better for the joints. Of course, nobody wants to do that and it won't work. So this is what we learned during recent years. And of course, there are a lot of positive effects of physical activity, but what I want to show you with this slide is it's not only for the body, it's not only preventing heart attacks, but it's also working on the mind, helping you relax, helping you sleep, finding friends, and getting an interaction with other people. And during the past years, there are more deaths related to physical inactivity than there are to smoking. So they say sitting is the new smoking, and this concerns all of us who are here. Now, why is it important to start early? I picked this example of muscular strength, but this would also apply for bone mass or motor ability or anything. Once you are young, you can do not much at all. Then your muscular strength increases, but it peaks at some time. And this is in your early 20s, unfortunately. So if you have a bad start and you increase your strength at the same slope, you won't reach the same amount of strength that you would have if you'd started earlier. So it's important to start as early as you can on your own level. And why might physical activity be a problem at all in patients with esophageal atresia? We heard a lot about that. There are frequent hospital stays, especially at a young age. Then there's developmental delay that is linked to that. Respiratory problems, which are present in 20% of esophageal atresia patients during exercise. And impaired lung function and exercise capacity. Reflux, low body weight and height, and of course associated malformations. But when we asked the patients, what are your biggest problems during exercise? They said those two. Being small makes you being selected last for the football team. So we tested 2 really small cohorts of children in pilot studies in order to find out which test to use. And those are motoric tests that are actually pretty similar, the Deutsche Motorik test and Dordel-Koch test, test motoric function on several levels, like balance, like strength, like coordinations. And in teenagers, we also did the shuttle run test, which is a measure for exercise capacity without having to do a treadmill exercise. So in the young children, we saw that all mean test scores were below the average, and especially strength was impaired, and especially patients who had lung problems had the worst results. But there were no symptoms at all during fun activities. In the older teenagers, there was a different picture. There was a great variety between the results, and the mean was average. So there were some who were really good at sports and some who were not good at all, just like in the general population. But we don't know which patients turned out to be good and which persons didn't. What we're trying to do now is use the shuttle run test, maybe as a screening option outside the hospital setting in order to test older patients who got lost to follow-up. And sports participation. EA patients participate in school sports just as everybody else. If they didn't, it was not related to esophageal atresia. And very many patients were members of a sports club. If you compare that to the general population, and CHD is here congenital heart disease. But the patients participated at lower intensities, and they didn't participate in competitive sports as much as others. And I always wanted to tell this to somebody, but I couldn't put it in the paper. Esophageal atresia patients didn't have to do chores at home. So this graph shows how many minutes of moderate to vigorous activity patients did during 1 week. So if you have to do 60 minutes a day, you have to do 420 minutes during a week. And you see that in the early years, esophageal atresia patients were less active compared to the general population. And then they were the same. And when they were older, there was a significant difference between the esophageal atresia and the control cohort. And that's what the pediatric surgeons kept on telling me. Oh, this is all just because of the associated congenital heart disease. So we looked for congenital heart disease in those children, and we compared esophageal atresia with CHD and a control group, and we saw that older patients with esophageal atresia who did not have CHD were just as inactive as CHD patients and much less active than the control group. So why are some people active and some are not? And there are some factors that concern all of us, which are younger people are more active, people from active families with active friends, higher socioeconomic status, good environment for movement, and a better physical self-concept, which is what you think of yourself you can do. And then there are some risk factors for inactivity, which is female gender, older patients, cultural background, environment, here meaning screen time. Screen time is a huge problem. And we looked at this in esophageal atresia patients, and the only thing that we found that increased physical activity was if siblings were members of a sports club, and that a low body weight and associated malformations, except for CHD, were a problem concerning physical activity. And all the other medical factors that we investigated, like the type of esophageal atresia, the type of repair, meaning not only open versus minimally invasive, but also primary versus secondary repair, did not matter in regards to physical activity in the long term. Also, the symptom load that they had now, esophageal alata, and the number of general anesthesias had no impact. And this is what we're looking at now. That's the physical self-concept. This is what you think that you are, what you think you can do. If you think you are well coordinated, have endurance, if you're athletic or strong, and you see that there is hardly any difference between esophageal atresia patients and the general population. And the biggest difference was in endurance, athleticity, and strength, but it was not significant. So what can we do to improve physical activity? Be aware of the problem that later in life there might be a decrease in activity. Be kind. Any activity is better than none. Don't make them go anywhere they don't want to go. But it's also in your hands. And if you establish an active family lifestyle from the start, you also set an example for your children. Be creative, create an environment where the children can move and not only lie on their back in a maxi-cozy. Choose the right sport, compromise. There's a possibility to get individualized recommendations, especially for school sports, if you need it. Never give up looking for ways to improve the symptom control and get to know your own personal limits as a patient. And last of all, be patient. It doesn't happen all at once. So there's the right activity for everybody. And I thank you for your attention.